Very good. Well, I'd like to welcome all of you to the Elder Voice Family Advocates webinar on ageism and racism in Minnesota senior living. I'm Chris Sundberg, and I'm Executive Director and founding member of Elder Voice. Elder Voice works to neglect, abuse, and exploitation of residents in long-term care settings. We do this by advocating public policy changes that better protect and provide quality care for elders and vulnerable adults. And we educate families, residents, public policy makers, and the general public about the state of elder care. I'd like to just take care of a few housekeeping issues. We are recording both voice and video of this session, and it will be available on our website at eldervoicefamilyadvocates.org. We've planned a 1-hour presentation with 45 minutes being the presentation and about 15 minutes being left for questions. But we can extend that another 15 minutes if needed. I ask that you use the chat feature to ask your questions, and then at the end, I will direct those questions to our experts. The theme for this webinar became very clear when looking at the Minnesota Department of Health daily report on COVID-19 impact data. Early in this pandemic, we saw that elders and people of color are significantly more impacted than others. Over 75% of the COVID-19 deaths are residents in nursing homes and assisted living facilities. People of color make up 63% of the deaths among adults under age 64, yet they're only 16% of the population. Our guests are here to shed light on what is driving this wide disparity. And it's a pleasure for me to introduce our first speaker, Dr. Titania Shippey. She is Associate Professor at the University of Minnesota School of Public Health and Associate Director for Research at the Center for Healthy Aging and Innovation School of Public Health. She has a PhD in Sociology and Gerontology from Purdue University, a JD in Civil Law, an MS in Sociology, and a BA in Sociology. Dr. Shippey is expert in aging, equity, quality of life, long-term care, racial disparities, cumulative inequity, access to care, and racial discrimination. She has numerous awards and recognitions. With that, Dr. Shippey, I'm delighted to invite you, and I turn it over to you. Thank you.
Yes, thank you so much, Chris, and thank you everybody for joining us. I am so honored to be able to carry out this discussion with all of you because, as we all know, we're living right now during unprecedented times of a global pandemic and forces such as racism and ageism being particularly exacerbated and impacting so many lives. And I think the first place to start is to start by having these honest conversations about our own communities right here in Minnesota. And so today we'll be talking about first identifying and trying to understand how ageism and racism are operating in Minnesota senior care, and hopefully engaging in a discussion with all of you in how we as a community can move forward. Slides take a little bit to advance. Steve, do you want to advance the slides? Oh, there it is. I'm honored to be joined by my colleagues, Adichinma Kisonu, Dr. Maisi Tao, and Alana Wright, and I will introduce each of them individually for their parts of the presentation. Okay. Oh. Let's see. Steve, do you want to do the next slide? And maybe I'll just ask you to do it for the land acknowledgement slide, please. Thank you. I would like to start with the land acknowledgement, and for those of you who are interested in learning more about the value and importance of doing this, I'm happy to share resources later. So we acknowledge that as representatives of the University of Minnesota, in carrying out this presentation, we gather on the traditional land of the Dakota people, past and present, and acknowledge with gratitude the land itself and the people. We take to heart and commit through action to learn and honor the traditional cultural values Dakota values of courage, wisdom, respect, and generosity. Next slide, please. We have 4 session objectives today, and as Chris shared, our goal is to have an interactive session with you, so we want to present enough material but also hear from all of you. The 4 main objectives are as follows. We would like to go through understanding and describing the prevalence of ageism in American society and how it translates to senior services with implications during COVID in particular. To try and, number 2, identify racism as a public health issue and also how it impacts long-term care in Minnesota and nationally. Third, share our team's most recent research on racial ethnic disparities for Minnesota nursing home residents and those who are receiving home and community-based services. And finally, we'd like to conclude with some resources, opportunities, and connections. And one of such is the Minnesota Diverse Elders Coalition that Alana will be representing. Next slide, please. So why talk about ageism? And I'm sure many of you have heard the term ageism. And what ageism is, it's stereotypes, prejudice, and or discrimination against people based on chronological age. And it's particularly against older persons. As World Health Organization states, ageism is everywhere. Yet it is the most socially, quote unquote, normalized form of any prejudice. Ageism stems from the assumption that all individuals of the same group, in this case older adults, are the same. And like racism and sexism, ageism serves a social and economic purpose, and that is to legitimize and sustain inequalities between groups. And it is not really about how we look. It is how about people who have influence and power who assign meaning to how we look. And so one of the pictures I have here, you probably have, it's a familiar photo for you. It's a photo that was used during the midterm election to scare younger people into voting by portraying older people as scary and debilitated. And that's what ageism does. It portrays use of older individuals as unworthy of attention and resources or unsuitable for employment. What's different about ageism, unlike other forms of discrimination, such as sexism or racism, is that ageism can impact all of us at different parts of our life course. Ageism can be both explicit or explicit and can be maintained and expressed on an individual level, so individuals holding biases against older people, institutional and or structural levels. And what research has shown is that ageism, in fact, in 2014, governments around the world as part of the UN Convention declared ageism as the most common source of justification for and the driving force against age discrimination around the world. Also, research has shown that ageism is pervasive and has been growing in the United States. And in fact, it's growing among all age groups, including older adults themselves. And what happens is that when older people internalize these negative attitudes about aging, they harm their physical and mental health and their opportunities for well-being and connection in society. Next slide, please. So some folks might say, well, you're talking about age discrimination, but aren't we all protected because in 1967 we have passed the Age Discrimination in Employment Act? It's been a long time. Well, of course, the act was passed in 1967, but as many policies happen, it takes time to implement and change societal discourse around those. And so in fact, an AARP survey that was carried out, I think in sometime in 2015, so and this issue has not improved in the last 5 years, has found that in fact, majority of older workers report discrimination at work. So you see 64% of workers say that they have seen or experienced age discrimination in the workplace. In 2018, in fact, the Equal Employment Opportunity Commission, which is the nation's workforce watchdog, issued a very negative report of the progress that has been made in protections against age discrimination. And their conclusions were that age discrimination remains a significant and costly problem for workers, their families, and our economy. In fact, our team's own research that was published 2-3 years ago found growing prevalence of age discrimination in workforce for women in particular. And what we found is that age discrimination for women started peaking around mid to late 50s and carried out into the 60s. And this was a national survey, and a number of women reported that they left the workplace because of age discrimination and experienced financial strain because of that, and long-lasting effects for their mental well-being and depression in particular. And these findings were particularly pronounced for Black women, and we'll be talking about how ageism and racism intersect as well. So next slide, please. I think these slides just take a little while to advance, but thank you, Steve, for doing it. So today, we really wanted to focus on long-term care. And really, I think I probably don't need to make even a very strong case for why long-term care in itself and the way that it is designed in the United States is such a clear example of ageism and how it has been normalized in our society. Indeed, even the delivery of long-term care, specifically segregating older people into long-term care facilities by age, is a clear example of ageism that we have sort of accepted as the status quo. And what it does, it prevents opportunities for age integration and opportunities for younger people to combat some of these negative stereotypes of older folks as frail and dehumanizing that we hold in our society in such high rates as we have seen. Also, research has reported high rates of quote-unquote professional ageism among healthcare workers. And what this is ageism that's held by folks who work in particular in emergency departments and acute care settings, but also long-term care settings, because most of their exposure with older people is with frail and sick older adults. And so the stereotypes about older people as being frail, sick, and debilitated are not countered due to their exposure. This research also finds that in particular emergency departments, which are seeing a rise in a number of older adults that are using them, are very poorly prepared to address the needs of older people because they use this disease-focused framework of care, which really doesn't account for diversity of needs and multi-social, psychosocial needs that older adults have. And then finally, ageism has been especially prominent during COVID. I am sure many of you could think of many examples, but just a few that I will share here with you include politicians making statements and public leaders that grandparents are expendable in the name of the economy. For those of you who are Twitter users, you might have seen and maybe have read about a very prominent hashtag on Twitter called #BoomerRemoval. And what the Twitter hashtag has been talking about is about all the money we're going to save with all these older people dying because of COVID. So why should we care, right? This is sort of a saving us pandemic from the expenditures for older adults. And what ageism has done during COVID, and this notion, you see it in the way media portrays older adults, is framing older people as one monolithic group and failing to acknowledge their demographic, health, and functional diversity. And really, in many ways, the discussion about older adults, and especially those who use long-term care, has been dehumanizing during COVID. And finally, one of the other examples of ageism during COVID is the lack of resources and attention that we've seen to long-term care settings. Somehow they're supposed to fend for themselves while they're providing care for many of our most vulnerable older adults. Next slide, please. Finally, getting closer to actually long-term care settings, studies have found also high rates of ageism among healthcare workers in long-term care facilities and administrators of long-term care institutions. When pulling these studies together, three main themes emerge. First one is the theme of providing substandard care to older adults. And this includes older adults reporting that they feel invisible and forgotten, perceiving older adults as no longer human, and older adults reporting that they feel that they're treated as an object in an automated fashion in long-term care settings. The second theme is not giving older adults enough privacy. And this includes lack of privacy when helping older adults with activities of daily living, such as toileting, washing, or dressing, letting older people having limited choices in things such as when and what to eat, when they go to bed or have a bath, and assumptions that older people are not sexually active. And then the third theme has been the controlling of the interactions and the using of inappropriate and diminishing language that happens in many long-term care settings with older adults. And some examples from the studies included examples such as excluding older adults from conversations, shouting at older people, using patronizing language toward older people, little assessment of the preferred way in which older adults would actually like to be addressed. And I'm sure, again, when we have discussion, many of you will have real life examples of ageism in long-term care settings that, again, has gotten normalized and somehow we're not fighting against as we should. Next slide, please. Ageism has been pronounced, as we've said, during COVID in society at large, but especially in long-term care settings. And why? Long-term care settings are at high risk for ageism because they house, as I've said, a number of our most vulnerable older adults. And one of the reasons for this high risk is because of how long-term care has been built, right? We have large facility sizes. About half of nursing homes are have more than 100 residents, as we know, in Minnesota, and also residents that who are housed in close quarters. So of course, the risk of transmission is going to be high in long-term care. We also know that the threat from ageism and COVID to residents in long-term care is not just a safety threat from the COVID infection, but also threat to residents' social and psychosocial well-being. Because as we all know, with no family visits policy, there have been massive disruptions to residents' social lives. And in fact, there are now studies that are coming out which are showing increased depression, weight loss, and disruptive behavior among residents due to feeling lonely, abandoned, and despondent. And we know that loneliness is a massive public health threat and a massive risk to one's is a high risk for mortality for people who are lonely and isolated. And so again, we need to have these policies to protect older people for the sake of safety, but often safety competes with quality of life and psychosocial well-being. And we should be having these discussions. How is ageism impacting and how we are isolating older people in long-term care without allowing them a chance to interact with their family members? And so, of course, we also know that family visits, my own research is finding this, is that family visits serve an important function of quality. And so when we no longer have family visits in long-term care, there are concerns that quality might decrease even more because there is nobody else to check around on residents. Next slide, please. Now, transitioning, in the beginning of this conversation, I said that what COVID has really done, COVID has really intensified the threats and exacerbated the disparities due to ageism and racism. And so starting with some basic definitions, what do we mean by racism? And again, the term has been used a lot. The definition that I really like is from Dr. Kamara Phyllis Jones, and a physician and also a former president of American Public Health Association. And she defines racism as a system of quote unquote structuring of opportunity and assigning of value based on race that unfairly disadvantages some individuals and communities, unfairly advantages other individuals and communities, and saps the strength of the whole society through the waste of human resources. Next slide, please. So as Chris also shared, if you've been reading the news, you likely already know that people of color and indigenous people have been disproportionately impacted by COVID. Just to show you a few statistics here, and there are many more right here in Minnesota as well, and we could share those with you if the time allows and share those as extra resources. But on average nationally, we know that Black and Latinx people have been 3 times more likely to contract COVID than their white counterparts. We also know that Black patients are less likely to receive a COVID test if they need it, and that disproportionately Black counties account for up to 60% of all COVID deaths in America. We also know that these disparities are happening right here in Minnesota, and if you're interested, we don't have enough time, so I'm not showing this, but there are interactive maps where you could see Minnesota rates of COVID by race, ethnicity, by county, and this is spread out all across the state. Where, Steve, if you could give us the next slide, I'll show you the age and race differences in COVID infections. And in fact, for Black and Latinx people, we see disproportionate impact of COVID for people of all age groups, as you see on this figure here. And this is from from the Centers for Disease Control from the end of May. But these trends have remained and have not, the disparity has not decreased. And as I said, is prevalent right here in Minnesota in our community. Next slide, please. So bringing it closer to long-term care, right? We started with racism and ageism in society as a whole. Well, what's happening with COVID and nursing home disparities? In fact, the few studies that have been published on the impact of COVID on nursing home quality have found very few associations with other nursing home characteristics and COVID infections. But a colleague of mine, Dr. Tamara Konecka, who is a professor at the University of Chicago, during her testimony to the US Senate said that there is, quote unquote, a strong and consistent relationship between nursing home racial composition and COVID infections and mortality. In fact, nursing homes with more Black or Latinx residents have reported at least one COVID case, which was nearly double the rate of primarily white nursing homes. Other studies that have come out since then, and I've cited some of them, also have consistently the same finding, and that is that residents of color have higher rates of COVID infections in nursing homes, and that nursing homes that house more residents of color are also more likely to have COVID outbreaks. Next slide, please. So what I'm going to show you here is to transition a little bit closer to the research from our team. And again, we will engage hopefully in a robust discussion to allow enough time for it. What our own research shows is that these disparities that we are seeing during COVID, in fact, have been COVID pre-existent, right? And it's just that now we're hearing more attention, and somehow many folks are surprised by these disparities. But there is a large and existing body of work, our own work included, which shows significant racial ethnic disparities in nursing home quality pre-COVID. They just became more exacerbated during COVID. Our own research of our team has focused on quality of life. And quality of life is a really important metric of quality, while other studies have primarily focused on clinical measures, which are also important. Quality of life is important because it gets at the person's overall well-being. A little factoid I share about myself is that I spent 2 years living in a retirement home during my doctoral studies. And it was during this time that residents told me that they don't want to be thought of as just patients. Yes, they were living in a nursing home setting because they needed care, but they're people first, as they told me. And so quality of life gets at activities, social engagement, relationships with others. And what our work has found in analyzing data from Minnesota, so this is all Minnesota nursing home residents, in the last 10 years, we found that Black and Indigenous residents report lower quality of life than their white counterparts, and in fact, the lowest among all racial ethnic groups. We find that the domains of quality of life, which have the lowest scores for Black and Indigenous residents are those on food satisfaction, meal enjoyment, meaningful activities and social engagement, and getting attention from staff. And these domains include multiple questions. And so questions might be like, do staff treat you with dignity and respect? Do you feel that they know you as a whole person? We also find that white residents who live in primarily white nursing homes have the highest scores on quality of life. Minnesota does really well in general on quality of life for white residents, but Black residents who live in primarily Black facilities have the lowest scores, and the gap has been increasing over time. Next slide, please. And so what I will show you in these next 2 slides, I will show you our 2 most recently published studies, hot off the press, which show analyses from Minnesota data to these findings that I just shared. And so if you look at this slide, what we have here, I am showing you 4 domains of quality of life. As I said, quality of life is a multi-domain measure, and so it has 52 questions that add up across different domains. The domains that have most disparity, 4 domains are shown here, and the study was just published online, will come out in press shortly. And what you will see, let's look at the domain of attention from staff. And I said it includes questions such as, do staff know you as a person? Are you treated with dignity and respect? And you will see that number of 7.4 is the overall disparity in satisfaction, in quality of life between white residents and residents of color. So 8-point difference, about 8 point, which is a meaningful and significant difference. What you will see in that, the number in blue, 1.5 points of that disparity is due to resident characteristics, because indeed, residents of color and white residents on average have different needs. Some of those are big age differences, and I can talk about some of those different resident profiles. The orange number, 1.5, is due to facility racial composition. So these are high facilities that have high proportion of Black, Indigenous, and other residents of color. You see that explains part of that disparity too. The gray number, about 2 points, is due to other facility characteristics. And those are factors such as percent Medicaid payment on a facility, staff turnover and retention, facility size, location. But notice that the yellow bar, the 2.4, is still the disparity that is not explained by either resident, facility, or facility racial composition characteristics. And this is why we started by talking about racism, because I want to be very clear that when we find these racial disparities and a growing gap in nursing home outcomes for residents of color, and we see these disparities during COVID, for COVID infections and mortality, they are not due to some genetic racial differences, which we know race is a socially constructed construct, but they're due to unobserved factors in our model. And what are those unobserved factors? Those are factors of institutional and structural racism, which Adi, in fact, will talk about briefly. We don't have time to go through all of them, but I just also want to draw your attention to food enjoyment. This is the domain that has the biggest racial ethnic differences, and they, again, are growing over time. And you will note that, again, in all of these domains, there is a significant proportion of disparity that is not just explained by resident, facility, or facility racial composition factors. Next slide, please. This is the last slide that I wanted to show you from my part of the presentation. And again, this is a heart of the press study. And what this work does, it's looking at disparities in quality of life in Minnesota nursing homes over the time point from 2011 to 2015. And what you will see here, I know there are a lot of graphs, but just look at the blue line. That blue is a dot, a solid line, are white residents who live in primarily white facilities. Low BPOC facilities with low proportion of Black, Indigenous, and other persons of color. So white residents in mainly white facilities. That's the line that's on the top. Notice the unadjusted, what that just means, that's just if you look at racial differences over time, you see white people are pretty satisfied. If you add resident characteristics, and we have a lot, various diagnoses, mental health, physical characteristics, demographics, that line looks a little bit lower, but in general is still pretty high. And then the last graph shows you what if you account in statistical models for resident and facility characteristics, and yet still, white residents in mainly white facilities are pretty satisfied and are doing pretty well. But note the line that's the lowest on the bottom, and that's that dotted red line with the diamonds, and that's residents of color in facilities that are high proportion Black, Indigenous, and other persons of color facilities. You will note that that line is considerably, and these are quality of life scores, those scores are considerably lower than those of their white counterparts who live in mainly white facilities, and it's going, the gap has actually increased over time. We also had we also asked the question as a team, what about residents of color who live in mainly high proportion Black facilities compared to living in mainly white facilities? And we really find no buffering effect for residents of color who live in white facilities. It's slightly, their scores are slightly better, but they're still considerably lower than for white residents who live in white facilities. So again, what our findings show, our body of work and that of other researchers, is that what we're seeing during COVID is not new. It's just that COVID has brought these disparities to attention, and hopefully now we can move toward addressing them. Okay, next slide. Now I would like to introduce my colleague, Odichinma Kisonu. She holds an MPH from the School of Public Health and is a fourth-year doctoral student in a PhD program in Health Services Research Policy and Administration. Adi brings a lot of experience and expertise to this topic, and she will take us through the next section of the presentation. Adi, it's you now.
Thank you. I was muted there for a second. Thank you, Tatiana. In this few slides that I'm presenting, I'm going to be talking about one of our recent papers that discusses COVID-19, racism, and long-term care. Next slide, Steve. So as Tatiana has said, and to be very clear, these inequities and these disparities, racial ethnic disparities that we see in long-term care are definitely not due to race, but are due to inequities based on racism. So things like systemic and structural racism, for instance, in housing sector, where people have different access to housing and mortgage opportunities, education, where people have people from marginalized communities have unequal access to high quality education, and things like that have led to adverse experiences, life experiences throughout their life course for Black, Hispanic, Latino, Asian, Indigenous groups. And the impact of this is that it has led to cumulative health disparities. Again, over their life course, if you don't have access to a well-paying job, for example, or good healthcare access that provides good insurance, you are more likely to have issues, when you are thinking of healthcare access and when you're thinking of your like managing chronic conditions. So you're more likely to have chronic conditions and more likely to have those chronic conditions mismanaged. What does that mean for your later life? It means that Black people, Indigenous folks, Hispanic individuals are more likely to be at higher risk for COVID-19. And other marginalized communities are also at higher risk for COVID-19 as they age. Next slide. So for instance, in nursing homes, as Dr. Tatiana Shippey talked about, nursing homes are a segregated place of care where you have older adults receiving care outside of separated from the community. But even within the nursing home institutions, we see that there is unequal access to care services for people of color and marginalized communities. For instance, Black people are more likely to live in nursing homes and receive care in nursing homes that are under-resourced and are understaffed. And so that increases their risk for COVID-19, among other things. Black people are also more likely to, or Black nursing home residents are also more likely to have lower rates of vaccination, so flu vaccinations, for instance. Similarly, Black and Hispanic folks are more likely to have lower report and have lower quality of care, and also report lower quality of life. And as you can see on the graph on the right, as Tatiana spoke to, Dr. Konetska's presentation at the Senate, you see that nursing homes, which are typically nursing homes that have a high proportion of Black residents, are more likely to have highest cases of COVID-19 and highest rates of death due to COVID-19. And then when you think about home and community-based settings, these are settings that are not your traditional long-term care settings like nursing homes. And over the past 2 decades, you see that the rates of people who are using these services have increased, especially within marginalized communities, so Black, Indigenous, Hispanic folks are more likely to use these services. And they report definitely disparities in quality of life and quality of services they receive compared to their white peers. For instance, providers that provide services for a higher proportion of Indigenous folks are more likely to score lower in terms of quality compared to providers of home and community-based services for providers who provide services for a lower proportion of Indigenous folks. So you can see that these disparities have existed prior to COVID-19. In fact, COVID-19 is just one undeniable example of how racism and disparities due to racism impact marginalized communities and communities of color. Next slide, please. One other example that I wanted to point out is, if you look at preliminary data from CMS, this was in June, this graph shows, or this collection of graphs shows COVID cases among dual Medicare and Medicaid populations. And this dual Medicaid Medicare population are the vulnerable, one of the most vulnerable populations for those who are receiving public assistance. And within this population, you can see the impact of racism, right? Where Black, dual eligible older adults who are typically receiving care in nursing homes have the highest rates, followed by of COVID-19 cases, followed by Hispanic and Asian compared to other racial groups. And in terms of ageism, you see that older adults who are dual eligible are more likely to have COVID-19 cases compared to their younger counterparts. Next slide. Now this brings us to the workforce. So we've talked about how there are disparities that have existed and how COVID, how they put marginalized communities at risk for COVID, especially for those who are receiving long-term service and support. But we also need to think about the long-term care workforce. Protecting our older adults also starts with protecting the long-term care workforce. And who are these people? These are staff, typically direct care staff, who are historically undercompensated for the care that they provide. And what is the care that they provide? They typically provide hands-on care from feeding, transferring, supporting recipients in all types of settings with movement, feeding, and other types of services. And they are disproportionately Black, Latino, and immigrant women. And they're also disproportionately from low-income families. So this set of workers are, one, more likely to even live in communities that are already impacted by COVID-19, and two, work in nursing homes or assisted living settings or home and community-based settings that are also disproportionately impacted by COVID-19. And so that already places them at risk for infection and also transmission to the people that they serve. So it has implications for their health and well-being, as well as the health and well-being for the people that they serve. And so, and on top of that, because of COVID-19, there's already increased workplace-related stress that they're placed in because they're usually short-staffed, and so they have to do more work than they typically do. And of course, because of the policies that restrict informal caregivers from accessing nursing homes, you see that there's even more stress placed on staff to provide services in an already very stressful environment, thanks to COVID. Next slide. And then quickly, I just wanted to talk about some of the recommendations that we discussed in our paper. These are, of course, just 5 of many other recommendations you can think about to address COVID-19 in the short term, but also thinking about how to disrupt structural and systemic racist policies that have led to inequities in long-term care in general. So the first thing is, it's really important to prioritize COVID-19 testing and providing personal protective equipment for workers and communities that are marginalized, for workers that work in nursing home settings, for instance, that are typically understaffed, especially those that serve a high proportion of Medicaid recipients. It's also important to think about the wages and benefits for long-term care workers. 58% make $30,000 and below per year. And this is not sustainable thinking about when you think about the value that they provide, especially in COVID-19, in this COVID-19 era. So it's really important to think about increasing wages as well as benefits such as hazard pay and access to better health insurance for our workers. And then finally, it's important to disrupt and change policies that perpetuate racist policies and that perpetuate racial disparities. Providers need to think about how to support the communities that they care for better to reduce racial disparities in general, and to think about how, on the federal level, how Medicaid policies can be improved to promote health and social justice for those who are primarily on public funded programs. And with that, I will turn it to our next speaker.
Thank you so much, Adi. I am very pleased to introduce our next speaker and a great colleague of mine and our team member, Dr. Maisi Tao. Dr. Tao holds her PhD from the University of Minnesota, and we had a great honor to have her as a member of our team on our federally funded work that's been examining racial disparities in nursing home care. She's currently an assistant professor and a director of Hmong studies at the Department of Anthropology, Global Religions and Cultures at the University of Wisconsin-Oshkosh, and she also holds a secondary appointment as an adjunct assistant professor in the Department of Family and Community Medicine at the Medical College of Wisconsin. So Dr. Tao, now we'll just turn it to you.
Thank you so much. Thanks so much, Adi and Tatiana, for basically laying the groundwork to think about the ways racism and ageism is impacted structurally, right? Looking at, racial composition of a facility, looking at income and resources. So I always like to give a little spiel about who I am in my training. So I'm a medical anthropologist, and what does that mean? So I really care about these structures of inequality that really impact health outcome. But as an anthropologist, I kind of take a much more microscopic view of things to look at basically what are the practices and discourses that help to kind of reify and resupport these types of structures of exclusion that we're talking about. And so, that's basically looking at things like culture, looking at people's health behaviors, people's ideas, the things that they say and the things that they don't say, right? And how does that create the types of cultures that we're seeing that then exacerbates certain forms of quality of life or health outcomes. And I do want to say, I do this specifically with the Hmong community. I do a lot of research with the Hmong community, but that's not to say this is unique just to the Hmong, right? I think that Hmong studies, right, doing work through the Hmong community allows us to kind of make strange more of this nursing home culture, right, and to not take it for granted. It allows us to understand much more generalizable questions of what it means to live in long-term, to experience long-term care. So to start off, let's see. It says I have control. Steve, do you mind doing the next slide? Okay. All right, so to start off, kind of thinking about how doing research with Hmong residents, what does illuminate us about the nursing home culture? So in my short time with Dr. Shippey and her team, I was able to kind of think about the ways in which nursing home culture really oftentimes is built around predominantly white nursing home residents, which is oftentimes what you think about is like a white grandmother, grandfather. But then how does that affect residents who then are much more, who have limited English proficiency or actually are not non-English speakers themselves? And so through our work, we were able to identify 4 things that really came out of the nursing home with Hmong residents. And so one is that they experience a lack of attention as residents who don't speak English. So I'm happy to talk more about the data later, but oftentimes their care was basically delayed because a lot of the nursing home staff members can't speak the native language of the residents, and so it's something that ended up getting postponed. And so family members talked about the ways in which sometimes their loved ones in the nursing home would, have care that was neglected for a long period of time. And they also experienced limited or disrupted forms of social relationships. And so for Hmong residents who don't speak English, they often were not able to connect with people outside of their ethnic group. And through my observation, Hmong residents who were able to speak English were able to have more friendships across ethnic groups. And then also the nursing home facility itself really structured ways in which it made it really difficult to maintain social relationships. So these Hmong residents were, sharing a room with another resident. And so it really incentivized large family gatherings to visit residents. Which made it really difficult because family often advocate for the Hmong residents. And then there's also experiences of lack of meaningful activities within the nursing home. And so when I was there doing some of the field work, you could see that the activities that they would put on in the nursing home were predominantly tailored towards white residents. So, even though Hmong residents loved bingo, they didn't attend the, I don't know why the slide went. They didn't attend the live music session where they played Johnny Cash, right? They weren't attending the popcorn nights or the movie nights. So those are, things to think about in which, what are some of the cultural activities that you're putting on, and how does it reinforce and support certain residents to thrive better in these places. And so one last finding that we found was that all of this came together to really produce an attitude resignation among the Hmong residents, feeling like they can't really do anything about their situation and kind of just accepting the conditions within the nursing home. And kind of bringing this back to COVID, we are thinking that, they're already experiencing forms of social isolation, experiencing an attitude resignation, that this perhaps could be even worse and more exacerbated with COVID. Okay. Oops. All right. And then, so, moving on, so I want to emphasize that, with it being nursing home culture, it's interesting the ways in which these are not things that people are overtly trying to do, right? They're not overtly trying to exclude or marginalize Hmong residents, but these are the types of practices that kind of give way and shape to the things that we were able to observe. And so, culturally sensitive care is something that a lot of institutions have been promoting to address racial disparities, kind of like what we've been describing. And so, what is culturally sensitive care? It's often, developing cultural humility, learning about other cultures, and through our field work, what we were finding was that culturally sensitive care was often promoted, that having people who look like the Hmong residents, and also people who are able to speak the language. And so through that, I was, as an anthropologist, is like, I want to unpack that a little bit. What does it actually look like in practice and in discourse? And so I developed this little model from our data to show the ways in which Hmong staff members, right, who are often said to provide culturally sensitive care, what do they actually do outside of looking like they're Hmong and also speaking Hmong, right? And so they were deeply involved with having to educate other nursing home staff members about how to care for diverse patients. So examples like teaching them how to put on the funeral garments of Hmong residents when they pass, but also being cognizant of other ethnic groups who practice differently. And then addressing the cultural needs of the residents. So that's just as simple as like making sure that rice is a food item menu. And that really required them to have to advocate outside of their actual job responsibilities. And I forgot to mention that these nursing home staff members they range from admin to nurse to social worker, right? And so it's not a specifically designated person to be doing these things. And then also, they have to also educate residents and family members about the culture of nursing home. And so I think this is the point where it's unique to think about the Hmong, to think about immigrant and refugee populations as they move into nursing home, who may not have the experience with nursing home culture and having to learn that. And so these staff members are tasked to do that. And they also explain that, like, biomedical culture as well, right? An admin had to teach Hmong residents about how to read their lab, which is not part of an admin task. And then all of this comes together to really create this huge emotional burden on these Hmong nursing home staff members, is that they're always constantly negotiating between their professional identities, their professional job duties, as well as their ethnic identity. And so there's a lot of emotional burnout. There's a lot of carrying these types of emotional anger or rage home as well, and just disappointment, but as well as personal satisfaction. I'm trying to go to the next slide. Okay. All right. And so to kind of summarize, culturally sensitive care through our work was equated to language and ethnic concordance. But to kind of link this back to racism and to think about racism as something that also affects nursing home care, is that I argue that culturally sensitive care also racializes Hmong staff members' form of care as different, right? It's marked as different. It's marked as something that's natural and innate, that comes inherent to these Hmong staff members. But yet, as you see, they're experiencing a high emotional burnout. They have no structures, no support, and are not compensated for having to do this additional form of labor on top of what they're already doing. And so, yeah, there's more to be done around in this area, but to really illustrate the ways in which racialization happens within the nursing home through these types of practices and culture. Thank you.
Thank you so much, Maisy. And please keep putting those questions in chat. I can address as we're going. And last but not least, I am very pleased to introduce my colleague, Alana Wright. It's actually Alana's birthday today, and she's doing this webinar with us. So happy birthday again, Alana. And Alana is representing Minnesota Diverse Elders Coalition. And so I'd love to have the perspective of a community group on this work. Thank you, Alana.
Thank you, Tatiana. As Tatiana said, I help coordinate the Minnesota Diverse Elders Coalition, and so I'll be talking about the work of the coalition as well as a recent community forum we had last November in North Minneapolis that talked about racial equity and services for older adults in Minnesota. Next slide, please. So the Minnesota Diverse Elders Coalition was formed by the Minnesota Leadership Council on Aging in 2019. Our purpose is to create healthy communities where older adults are valued and have improved access to high quality and culturally diverse supports for all older Minnesotans to live well. Our advocating priorities are to elevate the voice of Black, Indigenous, and people of color, as well as the LGBT communities, to explore health and social and economic equity, and lastly, to ensure the sustainability of the Minnesota Diverse Elders Coalition. Next slide, please. All right, so now I want to kind of give an overview of, like I said, this community forum we had last November in North Minneapolis. We had over 100 attendees, which definitely exceeded our expectations and attendance. Those individuals represented white culture, Black, Somali, Latinx. The purpose of the forum was to build collaboration across different community groups and members around the topic of aging and long-term services and supports, share findings from the University of Minnesota researchers on the needs of racially and ethnically diverse consumers and long-term services, and lastly, to create a dialogue between the University of Minnesota School of Public Health and community members around supporting the needs of racially and ethnically diverse consumers using long-term services and supports. And this forum was a partnership between the University of Minnesota School of Public Health and the Minnesota Leadership Council on Aging's Minnesota Diverse Elders Coalition. Next slide, please. So as part of the community forum, we had a great array of panelists. We had professionals from the field of aging. We had individuals in terms of clients or caregivers speak to their experiences within care settings. And then we also made sure that there was time for actually curated community table conversations. You know, that's one thing. And I think we all learn that that's a constant learning, that it's great to provide education to individuals, but it's also like we're doing today, and we're going to run a little over. So if you can stay on, we'll engage you in some questions to allow time for dialogue and for people to think about the questions you pose and for them to provide a response versus you just talking at individuals. So that was a key part of our forum we had last fall. And we had raised 3 questions to the different breakout tables. And the first question was, what are your experiences with finding long-term care for you or a loved one? And this is going to echo some of the things that were already discussed by my colleagues today. That would be language and communication barriers, burdens of finding appropriate care due to complex needs, barriers to accessing care in terms of rural versus urban settings. The next question we asked was, what are your recommendations for provision of culturally sensitive services and long-term care? Some of the responses we received were, care staff should be trained in cultural best practices that are person-centered, work with communities to start intergenerational initiatives, and better staff and service recipient ratios and wage incentives for direct care workers to improve quality of care. The last question we asked in our discussion groups was, what is the role of providers in ensuring health equity in long-term care? Some responses were, care providers should promote intentional diversity at leadership and management levels. The state should meet regularly with family and care resident councils for a more holistic understanding of people's experiences. And community members should become better advocates for older adults within the community. I know we are near time, but I would like to leave you with one verbatim quote from one of our participants, and I think it kind of sums up, has been a reoccurring theme throughout this webinar, and that was, color should not matter. Dignity should be first and foremost, regardless if service recipients have Medicaid or private pay. First, treat them with dignity. And now I'll hand it back over to Dr. Shippey to close out and allow for questions from the audience.
Thank you so much, Alana. And so to conclude, and again, I do hope you can stay with us longer and engage in discussion. When we discussed all of the information that was shared, there are many recommendations that could be given, and Alana shared some of those, and I think those are very concrete recommendations. But broadly, the implications that we see is first and foremost the need for institutional and system level change, right? We see these disparities on the institutional level, and hence we need to push for changes in how these institutions deliver care. Absolutely, we need more resources, as Adi shared, for nursing homes with high proportion of Black, Indigenous, and other residents of color, especially during COVID, but also beyond COVID. We need to invest in quality of life initiatives for our Indigenous residents and those from communities of color, because as our research shows, their quality of life is lagging right here in our own Minnesota nursing homes, and that gap is growing. We absolutely have a need for culturally sensitive care, and Dr. Maisi Tao presented some ways in which staff from those communities are carrying out that care, even though they're not compensated to do so. We need more support for staff, especially from communities of color, and wages, but also other supports were some of the recommendations Adi shared. And finally, we need to be mindful of and encourage greater engagement and attention and appreciation to the role of family members and building meaningful partnerships with community organizations to address some of the disparities we see. So we conclude, it's 1:58, and I see that there's a question that came in through chat. Great, I was going to say, give us some questions. We're staying here at least until 1:15, but we're also mindful for those who need to leave on time. Chris, did you want to conclude us, and then we can engage in answering questions?
Thank you. And first of all, wonderful presentations from all of you. Thank you so much. And what you are all telling us and what you have studied is exactly what our resident and family members are experiencing each and every day in long-term care facilities. And I want to make it clear to everybody who's participating here that we are going to be pursuing a number of public policy changes here in Minnesota that hopefully address some of these issues. And we invite your support and your help. Among the things immediately that we're working on is during all of our numerous special sessions, we are trying to make sure that we have enhanced protections for the residents in long-term care. And because it's been clear that the impact of COVID-19 has exacerbated the problems in these facilities, and we need to improve the care. much of what we're seeing stems back to staffing issues. Staff need to have a livable wage. They cannot be expected to provide great care, which I know most of them want to, but yet be paid at substandard levels. And many of these staff are immigrant community, and we need to better enable them to be successful in that work, as well as for the residents themselves. So I would ask that you let your legislators know that you would like them to address in the special session enhanced protections for the residents living in these facilities. With that, and then just a reminder that all of this has been recorded. It will be on our website, and it will be available on our social media as well. Feel free to share it widely with anybody that would have an interest. And each and every one of us has our contact information available here. And I think I can invite any of you to contact us individually as well. Let's start with some of the questions that have been coming in. Odie, can you address more to the public policy ideas within Medicaid that can improve the health and social justice for people of color?
Hi, thank you for that question. I think that's a very great question. I don't know that we have all the answers yet, but we know that that people who are primarily on Medicaid, so for instance, nursing homes that serve a high proportion of Medicaid recipients are more likely to experience lower quality of care. So it's typically based on the resources that those nursing homes have. So if you use the example of COVID-19, under-resourced homes, especially those who serve high proportion Medicaid, are typically underfunded from the get-go, right? Because Medicaid has lower reimbursement. And so they're already strained to provide resources. So one start could be even looking at reimbursement, right? Because we need to empower nursing home providers who understand the communities they serve to help direct how best to improve those services. But if they're already under-resourced, that is based on reimbursement, it's kind of hard to sort of stretch themselves further. So one of the things I would say definitely is to even start with the reimbursement policies. How can we empower nursing homes and other nursing home and assisted living to cater to Medicaid recipients? How can Medicaid and public funders support them through increased reimbursement? Because some studies show that when you increase reimbursement, then they are able to invest more in infrastructure and resources that can help support the needs of marginalized communities that they serve. But there are definitely other ways, but that's the one I will talk about. I don't know if Dr. Shippey has something to add to that.
Thank you very much. One person has suggested that we have more webinars on proposed legislation or public policy. I can assure you, you will be seeing and getting invites to future webinars that will be covering these issues, and maybe very shortly, we'll see. Also, Dr. Tao, do you have an example of a law that prevents culturally appropriate care?
Thank you for that question. So I didn't actually look at law, but there were some procedures during my time of fieldwork in the nursing home that I noticed that really made it harder for some of the Hmong staff members to continuously provide culturally sensitive care. For example, the Hmong staff members were actually getting Hmong specific food, buying it out of out of the money that the residents gave to them. When they're not working, they would go and buy it and they would come back and bring it to the nursing home. But there was an issue around money and in terms of policy. I think one resident gave money to a staff member, and that money never came back. And so the nursing home basically implemented an entire policy that staff members should not be receiving resident money to buy anything on behalf of the residents. And so that really limited the Hmong residents' ability to even get ethnic specific foods.
Thank you. Earlier, there was a question that came in regarding, especially Dr. Shippey, your discussion and your research, and that is, was this just a focus on nursing homes, or was it broader? And I'd ask that you kind of expound a little bit on that.
Yes, definitely. Great question. And I typed a little bit in the response, and the short answer is that most of the research we presented is on nursing homes, in part because of availability of data, right? So researchers need data to be able to analyze. And as many of you here probably know, and that's why we're also looking for changes in Minnesota, assisted livings are, very minimally regulated, and also there is very little publicly available data on assisted living, which makes it very difficult to do research on assisted living. And so the few studies that do exist on assisted living look at, it's typically a few facilities, so it's not a representative generalizable sample. But I will say that in our own research, we've just recently published a study that's looking at Minnesota recipients of publicly supported home and community-based services, so Medicaid-funded home and community-based services. And what we see in that population is, again, the continued significant racial disparities in satisfaction with services that are received. And in fact, in that work, we also note significant gap for users with limited English proficiency, to Dr. Tao's presentation, who seem to have the lowest satisfaction and lowest use of services, maybe often because they don't know how to get help or don't get the help that's needed. So clearly, these issues that were brought up for nursing home are also persistent and real for other types of settings in home and community-based services, assisted living included. But we also know assisted living is primarily private pay and primarily white. So there is also a segregation of types of settings, right, where we see residents of color using nursing homes at higher rates.
Thank you. Another question here, Minnesota, the training that is required is only 8 hours within 140 hours of employment. Any suggestions how we can best culturally prepare our unlicensed personnel?
I could start, and I'm thinking maybe Alana and others could also, share their recommendations. I think clearly there are multi-pronged approaches that are needed and system level changes, right? So we need to provide support in time and compensation to provide these trainings. I know that nursing home staff turnover is really high. I know that it's so hard to pull people from shifts. That's why it's so hard to do any trainings in nursing homes and other long-term care settings because of shortage in staffing. And so we need to, again, this is system changes where we are accepting ageism and racism as status quo. And so by challenging and calling these disparities, I think that's right, legislation, but also changing how nursing home practice is done, right? If we're going to, it's not just increasing the numbers of training, it's also building a culture of care, which honors and sees people for who they are. But maybe others have other recommendations.
No, I think in a nutshell, you answered that well. Of course, it would be to allow for more hours within that training, but more needs to happen, like you said, systemically, to really move this work forward. So, and I guess one thing I would add, that in addition to whatever training is required initially when someone's get hired, to have that be an ongoing requirement of their employment versus a one-time deal with regards to cultural humility and cultural responsive care and the needs of their residents, that be something that is talked about on a regular basis within that work setting.
And I think I'm just going to add a little bit. As an anthropologist, we try to advocate other people to kind of develop a similar kind of lens, right, where you're also very reflective of yourself and your own personal biases. And so culturally sensitive care is not about actually having this wealth of knowledge about other people's culture. It's really a much more introspective kind of reflection about you yourself, the kind of biases you hold, what you think is normal, right? And really challenging that and making that strange and being open to other worldviews, ways of being in the world, right? And kind of bringing all that together and its differences and making it possible.
Thank you. And another question, does any of the new regulation for assisted living address directly or indirectly racial disparities? Is there a way for the new assisted living report card to address racial disparities? So part of that question I'll direct to you, Dr. Shippey, but indirectly is probably the only way that racial disparities have been dealt with. And we know that's an area that needs a lot more work. We were able to get a baseline of assisted living regulation in place at the last legislative, in the 2019 session. We knew full well there were a lot of issues left on the table, and these are among the more important issues that we have to come back to. And as long as I'm on the assisted living issue and the regulation, just want to point out to everybody, Minnesota was the only state that did not license assisted living facilities in any way, shape, or form. We were successful in getting major legislation passed last session, 2019, and it was to be going into rulemaking and become effective August 1st of 2021, next year. As a result of the pandemic, the Department of Health has redeployed 90% of their staff to address the pandemic issues, which has left them, inadequately staffed to handle, the completion of the regulation. And they are asking that legislators give them a delay until August 2022. Now, as much as we understand the pressures and issues that they have to deal with in terms of handling the pandemic, it does nothing but harm the residents to further delay the licensure. Licensure establishes care standards, infection control standards, all of these things, staffing standards. And it's all of these things that we are seeing be glaringly exposed during COVID. And so we're not supporting a delay in licensure, even though it may help whether legislated, or may happen, whether legislated or they just don't get it done, the Department of Health. But we do, if that is to happen, it's all the more important that this package of protections that we're advocating get put into place, and get put into place immediately, as soon as possible. And anybody who wants to get more information on what those protections are and what you might want to do, please reach out to me, Chris at eldervoicefamilyadvocates.org. Dr. Shippey, I'll let you.
Yes, it's a great question and probably a good one for us to conclude on. And unfortunately, again, it speaks to the normalized nature of racism and ageism that we see, and the continued need for all of us to join forces, I would say, to push for it. So I am involved in helping design, sort of from the research standpoint, the assisted living report card. Adi, in fact, is a member of the team, and I will credit Adi with specifically raising the question, how are we addressing racial and ethnic disparities, and how this work has been designed, and who is at the table, right? Because many of our stakeholders have primarily been been white, family members and residents, and not getting the voices of residents of color. I will say that currently there are now specific, as Chris said, direct initiatives to address racial disparities as part of the report card, but there are indirect strategies. So for example, by collecting quality of life surveys, this will be the first way to see how are residents of color, indigenous residents doing in assisted livings. Are they satisfied with the care that's being delivered to, that's been given to them? Certainly there are structural issues in who gets access to assisted living with ability to pay. And so that's another sort of big issue in getting at equity in assisted living. Adi, did you want to add anything and we can conclude?
Yeah, I think, you know, as part of that question and conversation about how we address racial disparities in assisted living through the report card that's being developed, we are trying to also embed questions that specifically get to gaps in experiences by people from communities of color. So, and you know, there's always feedback from the public, so we entertain and we look forward to the state continue those conversations with communities on how to make sure that we are capturing it, or how the state is capturing it through the assisted living report card going forward.
Well, with that, I thank everybody for participating in this webinar, and we hope to be offering more in the near future to explore further some of the issues that we started to raise today. Thank you, and again, come to the Elder Voice Family Advocates website to get a recording of this presentation. Take care.
Thank you, everyone. Thanks for joining.